Welcome to our presentation, The Influence of Spinal Manipulation on Patients with Lumbar Spinal Stenosis, a pilot study. My name is Dean Smith. I'm from Miami University, and I'd like to thank my co-authors, Katie Pohlman and Christopher Malaya from Parker University, Josh Haworth from Oakland University, Katie Luca from Macquarie University, and Dr. Kurt Olding from Minster Chiropractic Center. A couple of years ago, I was contacted by Dr. Olding, who is an instructor with James Cox of Cox Technic. They have had much experience doing case studies, and they were particularly interested in documenting the progress of patients with spinal stenosis under chiropractic care in terms of both postural stability and performance analysis, which is what our team enjoys researching. And it helps that Dr. Olding's office is not far from Miami University. Lumbar spinal stenosis can cause significant pain, interfere with activities of daily living, such as the ability to sit to stand, to walk, and may result in postural as well as dynamic instability and progressive disability. Due to the symptoms and functional impairments associated with lumbar spinal stenosis, chiropractors will see these patients frequently in practice. In a large multi-center observational cohort study, 33% of 368 patients with spinal stenosis indicated having chiropractic treatment in the past. Emerging evidence is finding that manual therapy, including spinal manipulation, as well as individualized exercise, provides improvement in symptoms and physical function in patients with lumbar spinal stenosis. The purpose of this study was to pilot a pre-test, post-test, open-label design of spinal manipulation on physical function and symptoms in patients with lumbar spinal stenosis. Patients accepted into this study had to be at least 48 years of age with a clinical diagnosis of lumbar spinal stenosis. As you'll see, all of the subjects were significantly older than this 48 years, however. The clinical diagnosis of lumbar spinal stenosis was taken from this study here. Spine of 2016, an international Delphi study on the clinical diagnosis of lumbar spinal stenosis. In short, the criteria were that the patient has leg or buttock pain while walking, the patient feels relief of symptoms with bending or flexing forward, patient feels relief when using a shopping cart or bicycle, patient has motor or sensory disturbance while walking, patient has normal and symmetric foot pulses, patient has lower extremity weakness, patient has low back pain, and duration of symptoms for more than 1 month. In addition, they are able to stand and walk without assistive devices for at least 20 meters, and they're able to give written informed consent and complete interviews and questionnaires in English. The exclusions were fracture, serious comorbidities, progressive neurodeficit, previous manipulation within the past month. Once patients were deemed eligible to participate and provided their consent, the rest of the study was organized as follows. There was a baseline visit pre, which included questionnaires, performance tests, and balance measurement. There was a baseline visit post, which included balance measurement only, and that was immediately after treatment on the first visit. Then the chiropractor determined the number of visits and the course of treatment, and there was a mid-treatment visit where there were questionnaires, performance tests, and balance measurement, and finally a last treatment visit, similarly with questionnaires, performance tests, and balance measurement. We did have unequal N. There were a couple of people that we lost due to follow-up, and a couple of people we just didn't collect the balance measurements post on. Participants in this study received Cox Technic Flexion Distraction and decompression type of spinal manipulation. And this is shown in the image to the left here. So here's the technique being applied to a particular patient by Dr. Olding. The number of visits were determined by the chiropractor, in this case, a Cox certified chiropractor. The questionnaires in this study were collected using REDCap. We collected these at baseline visit, mid-treatment visit, as well as the last visit. The questionnaire specifically included the Zurich or Swiss claudication questionnaire, and this asks about pain intensity and frequency, along with ischemic symptoms such as weakness and numbness in the legs and feet, as well as how their spinal stenosis affects activities of daily living such as walking distance, as well as comfort while walking. The ABC-6 is a questionnaire designed to assess balance confidence and fear of falling, and it includes questions such as, how confident are you that you will not lose your balance or become unsteady when you stand on a chair and reach for something? We also included numerical rating scales to assess pain severity from 0 to 10 for low back pain and buttock or leg pain. A perceived global impression of change score was collected at mid-treatment and final visits to assess overall change scores. Our performance measures were measured at baseline, mid-treatment visit, and last visit. Some objective functional tests for use with lumbar spinal stenosis have been introduced and have found their way into clinical practice, such as the timed up and go test and the 5-time sit to stand test. Their proposed advantages include quick execution, high repeatability, and straightforward interpretation, while also providing an objective dimension to clinical assessment. In addition, many patients actually prefer functional tests over questionnaires. The 5-time sit-to-stand test involved the patient standing up fully, then sitting down again, landing on the seat firmly 5 times as fast as possible. The timed up and go test has the patient walking to a line that is 3 meters away, turning around at the line, walking back to the chair, and sitting down. The time to completion for both of these tests is measured with a stopwatch, and both tests involve dynamic stability as well as speed of execution for best results. Balance measures were collected using a B-Trax portable force plate and were measured at each visit. Specifically, patients had their eyes open and eyes closed for 30 seconds on each trial, and we assessed anterior-posterior, medial-lateral path length, as well as sample entropy and mean frequency. As we can see off to the right-hand side here, here's the B-Trax portable force plate that people stood on, and this squiggly line indicates the anterior, posterior, as well as medial lateral movements that take place when the person changes their center of pressure on the force plate. For this pilot study, we looked at the following statistical analyses. For questionnaires and performance comparisons, we compared baseline visit and mid-treatment visit, as well as baseline visit and last visit. For the balance or postural stability comparisons, we compared pre-post on the baseline visit, as well as pre-baseline visit values to the last visit. We used repeated measures analysis of variance, and we set p less than equal to 0.05 for significance. On this slide, we can see our participant characteristics with an average age of 83.5 and a range from 74.9 years of age to 95. So a good range within our elderly population. We had 4 males and the rest female. And the BMI you can see for both males and females was in the overweight category. Anything between 25 and 30 is considered to be overweight by BMI standards. And it's interesting to note that higher BMIs are related to risk of fall, particularly when it gets to the obese category above BMI 30. Here we can see the results from our questionnaire and performance outcomes. We've divided things up into baseline visit, mid-treatment visit, and last visit columns. It's important to remember that we did 2 assessments from baseline visit to mid-treatment visit, and these asterisks over here indicate a significant difference, statistically significant, at a p less than 0.05 level. We also did a baseline visit to last visit comparison, and the symbol over here represents, again, a statistically significant difference between baseline visit and last visit. You can see that each of our questionnaire and performance outcomes statistically improved during the course of care. We did not measure PGIC, or patient global impression of change, in terms of statistical significance, but it's worth noting that a score of 6 indicates better and definite improvement that has made a real and worthwhile difference. Results for our balance assessment from the B-Trax force plate indicated that AP sample entropy reduced from 0.19 pre to 0.166 post at baseline, and this was statistically significant, and it indicates a shift to a more regular and repeatable or periodic type of movement on the force plate. The mean frequency of postural movements reduced from 0.71 pre to 0.637 post, also at baseline visit, and that was statistically significant, which indicates less frequent sway or oscillations. There were no changes in balance found between baseline visit and last visits. In summary, we found statistically and clinically significant changes in objective and subjective outcomes found after a pragmatic course of spinal manipulation in lumbar spinal stenosis patients. We also found that 2 quiet stance postural measures were statistically significant on the B-Trax force plate, and our current thought is that future investigation should use a more dynamic balance task to demonstrate greater effects. Thank you for your attention. Here are some acknowledgements.